We're going to review the AMSR National Medical Student Curriculum content in radiology. AMSR guidelines cover entire head-to-toe content topics for medical student education. We're going to cover abdominal imaging, specifically focusing on techniques used in abdominal radiology. The first section will be on radiography, and the second section will be on cross-sectional imaging. Radiography covers both static images, for example, KUB, which stands for kidney, ureter, bladder, and also dynamic imaging, which we will cover item 2 through 6. This is a radiograph, an upright radiograph, meaning the patient is standing up. There are different ways to acquire diagnostic radiology images. The first one is with the patient coming to the radiology department. The patient is standing upright. This is the radiation source, and this is the detector that absorbs the radiation and creates images. The second way is to acquire the images using a portable machine. As you see here, the machine is taken directly to the patient and images are acquired. There are key differences. Number one, typically the image quality is better on using these machines compared to portable because you are able to control for the distance between the radiation source and the detector, which is important for image quality, and patients are upright and are typically have better positioning. There are different positioning for acquiring radiographs. Here we see anterior posterior AP. The radiation source is here and the patient standing facing it with the detector in the back. Here, because the heart is closer to the radiation source, the heart will be bigger on the image. In contrast, the PA position, posterior anterior, the radiation source is in the back of the patient and the detector is here. You can imagine if you had a flashlight and you were standing between the flashlight and the garage door. If you were facing the flashlight, then the image is going to be projected on the garage door. And if you come closer to the flashlight, the image projecting on the door will be larger. Similarly, because the heart is closer to the source, the flashlight, the heart will be larger. In contrast, when you're turning towards the garage door with the flashlight beaming, the heart is closer to the door, so the heart will project smaller. Those are one way to differentiate AP from PA. Portable radiographs are typically acquired AP, and radiographs acquired in the radiology department are typically performed in the PA position because the image quality is better. We will discuss fluoroscopic imaging, but with fluoroscopic imaging, you can have the patient turn into various oblique position to highlight different anatomy parts. This is an example of an upright position. The radiation source is here and the detector is behind the patient. This is what an upright radiograph looks like. This is an example of small bowel obstruction. The bowel here is dilated and you see these fluid level that happens because the patient is upright. This is a lateral projection. The patient is turned on the side and this is the detector and the radiation source is coming through this way. And this is what a lateral projection looks like. This is a supine position. The patient is laying flat, the radiation source is above the patient, and the detector is behind the patient. When the patient is laying flat, you no longer see the typical air fluid level that you see with the patient standing upright. So in a patient with small bowel obstruction, because of the layering effect, you lose the air fluid levels. This is a cross-table lateral. This is the detector. The beam is coming towards the patient from the side. This is an example of a cross-table lateral image. And we see there's lucency, this dark density, and this is the density of air. And we see the lining of the small bowel, and we see air on both sides. This is called a regular sign, and this is consistent with free air in the abdomen, which means that there is a bowel perforation. The cross-table lateral positioning can be very helpful if the patient cannot move or rotate. Here we have a patient in right lateral decubitus. The patient is on their side, and this is a radiation source and the detector. This is the image that we can get from patient who is on their lateral decubitus position. If you're concerned about free air in the abdomen, then you want the left side down and the right side up so that you can have the liver interface to evaluate for free air, which will rise to the top. This will not work on the other side because of overlying bowel that can obscure free air. That's a summary of KUB and various positioning used in radiography for KUB. We're going to review barium swallow and modified barium swallow. Barium swallow is used to assess patients' swallowing capabilities using barium, which is a type of contrast agent. This is an example of a modified barium swallow, MBS. This is used to assess patients' swallowing mechanism and determine if they can safely eat and drink various consistency of liquids and solids. In contrast to a modified barium swallow, this is a barium swallow, also known as esophagram. For an esophagram, we look at the entirety of the esophagus and as it drains into the stomach. These are images from Indiana Radiology online tutorial. This is the positioning that we use for esophagram. Here, the patient is upright. The patient swallows in an upright position. Here's the position in an oblique position. In radiology, we like to have more than one view. So the patient swallows in the oblique position. The last part of the esophagram is the patient in a right anterior oblique position. And here we can evaluate the primary and secondary peristalsis of the patient. So we evaluate both an anatomical structures as well as functional evaluation of the esophagus during an esophagram. These are the images we obtained. This is the patient in frontal position as they swallow the contrast. Here in the left posterior oblique position, we acquire the images again with the patient swallowing a bolus of contrast. Here are the images with the patient laying down in the right anterior oblique position, swallowing to look for primary and appropriate secondary peristalsis. Here we see a small hiatal hernia with part of the stomach herniating up into the thoracic cavity. This covers the modified barium swallow, which evaluates the swallow mechanism, and the barium swallow, also known as esophagram, which evaluates the structure and function of the esophagus. Now we're going to review upper GI, which is a combination of barium swallow or an esophagram plus the evaluation of the stomach. This is an image of the stomach from Wikipedia. The fundus is in the most superior portion, followed by the body, and then the pylorus. We have the pyloric sphincter, and then the proximal duodenum. This is a lesser curvature of the stomach, and then this is a greater curvature of the stomach. This junction between the esophagus and the stomach is called the gastroesophageal junction. The first part of the stomach is called the cardia. During the upper GI, we can evaluate all segments of the stomach as well. Here we have the fundus of the stomach up here, and then this is the body. We have the patient rotate 360 degrees and acquire images as they rotate on the table. Here is a frontal radiograph, and now we see that the contrast is filling the fundus of the stomach, and now we can see the body of the stomach very well, as well as the pylorus, and there's contrast that's now emptying into the proximal duodenum. Here, the patient continues to rotate, so now we can see better the pylorus and the proximal duodenum. Here we can evaluate the duodenal bulb. And here's an improved distension of the duodenal bulb. The upper GI can be used to evaluate nausea, vomiting, unexplained dyspepsia, and other presentations that might be related to either the esophageal or stomach origin. This is a double contrast study. Both the esophagram typically as well as the upper GI part is done with combination of both contrast that we see here, which is bright, and air. So patients are asked to drink effervescent crystals, which are like Alka-Seltzer and provides both air and as well as contrast. So we call that double contrast evaluation. We're going to now talk about small bowel follow through, which is evaluation of the small bowel. Here's an image of the bowel from UCSF website. The small bowel is divided into the jejunum, which is the proximal small bowel, and the ileum in green, which is the second half of the small bowel. And then this is the colon and the appendix. The small bowel can be evaluated either by radiography, which is what we're going to see here, but we can also use MRI and CT enterography and MRI enterography to evaluate the small bowel. CT and MRI enterography are better to evaluate the anatomical as well as improved characterization of both small bowel thickness and small bowel abnormalities. We use radiograph small bowel follow-through in limited instances, typically in the inpatient setting now, to evaluate for small bowel obstruction. In evaluating small bowel using radiograph, we have the patients come to the radiology department and we get a baseline radiograph. Then we have the patient drink contrast and we evaluate the proximal as well as the distal small bowel at various time intervals. So here we see the jejunum, and now we're starting to see the ileum. And we take this every 15-20 minutes until we see the contrast in the right colon as we see here. Small bowel follow-through can be performed in patients whom you're worried about small bowel obstruction as well as small bowel abnormalities. But now with the advent of CT and enterography for patients with Crohn's and other forms of inflammatory bowel disease such as ulcerative colitis, MR enterography is the recommended study of choice for disease evaluation and characterization. Now we're going to talk about enemas. We can have double and single contrast enemas. This evaluates the rectum and the large bowel or the colon. This is the Wikipedia image of the large bowel. This is the anatomy of the large bowel. We have the rectum, the sigmoid, the descending, transverse, and ascending large bowel. For a barium enema, a rectal catheter is inserted into the rectum and contrast is slowly injected. This is routinely done in pediatric population. Here we have the contrast injection and the patient is rotated laterally to look at the evaluation of the sigmoid, and then the contrast is injected until the entirety of the colon is evaluated. Here we see that the contrast enters and goes into the ascending colon. This is a dynamic process, so you're evaluating the contrast as it fills the length of the colon. That's the single contrast enema. Double contrast barium enema is when both contrast and air is insufflated into the rectum throughout the colon. The double contrast enema was done previously for screening colon cancer, but now either colonoscopy or CT colonography are indicated for colon cancer screening. Our next topic is water-soluble enema. Water-soluble enema is different because of the type of contrast used. Barium is not absorbed by the bowel, and the patients typically excrete it when they defecate. In contrast, a water-soluble enema is performed with contrast that is absorbable by the peritoneum and the body. And we will use water-soluble contrast when we are concerned about perforations in the setting of obstruction, for example, or bowel leaks that we might see after surgery, and in some cases, fistula evaluation when we think the contrast will go in extraluminal spaces. In these settings, water-soluble contrast is useful because if it does go into the peritoneum from a bowel perforation, the peritoneum will reabsorb the contrast and excrete it renally. The next topic is intravenous pyelogram. Intravenous pyelogram is used to evaluate the collecting system in patients who have hematuria. Now we have CT urogram, so that has replaced intravenous pyelogram, which is not performed anymore. The final topic is cystogram and vesicoureterogram, which evaluates the bladder as well as the urethra. This is the normal bladder and urethral anatomy of a male. This is from Wikimedia Commons. We see the prostatic urethra, the membranous urethra between the prostate and the urogenital diaphragm, the pendulous urethra, which is at the base of the penis, and then we have the penile urethra. Here's an example of a VCUG. The Foley catheter is within the patient's bladder, and then it's slowly filled with contrast. Then we do evaluation of the bladder wall as well, and have the patient turn to the left and then to the right. Here we see that there's a small reflux into the right ureter in contrast to the normal other side where there's no reflux back up the ureter. This is mild reflux. And then we have here that you see that the reflux is worse now. It's going up into the kidneys, and the patient has bilateral reflux now that we are able to assess. We normally should not see the ureter or the pelvic collecting system opacify as we do here. The final step of the VCUG is to have the patient void. So now the patient is voiding, and you see that the prostatic urethra is now becoming more present. We are then able to assess the urethral anatomy when the patient voids. A cystogram is just the evaluation of the bladder, in contrast to voiding cystourethrogram, where we have both the evaluation of the bladder as well as the urethra as the patient voids. This is the summary of techniques used in abdominal radiology, specifically focusing on radiography. Next, we will talk about techniques specifically involving cross-sectional imaging used for abdominal radiology.